With that note, we're going to move forward, and I wanted to introduce our opening keynote speaker. Our opening keynote speaker is Dr. Miriam Lusberg from the Yale School of Medicine. Miriam is the director of the Breast Center at the Smilow Cancer Hospital and the chief of breast medical oncology at Yale Cancer Center. She's been recognized for her patient-focused care. Her work focuses on improving long-term outcomes for patients with breast cancer who have developed side effects associated with their treatment. Today, Miriam will be talking about the successes and gaps in symptom science and how to best collaboratively move the field forward. Thank you, Miriam, for being here.
Thank you so much, Anne. And I really enjoyed the last segment, the conversation with Sandy. And thank you for all the participants for being here. And thanks to the planning committee. So let me just, 1 second. There we go. So my disclosures are listed here and they're not relevant to the content of this talk. And I'm going to give you an overview of things that you actually know well, which is as cancer survivors in different stages and different trajectories, you have all experienced different levels of symptom burden and have seen it impact your quality of life. So I do want to acknowledge that you are all experts in this area. But I will be your guide and highlighting a bit the science of symptom management, what our current gaps are, and what our future directions will be. So what is quality of life? Again, this is what's important to you and what does it mean to you? Certainly, there are scientific definitions of healthcare related quality of life. But it's really a broad, multi-dimensional concept. And it's really subjective evaluation of things that both positively and negatively impact your life. So throughout today and throughout this presentation, I hope you think about what's important to you, because we all have obviously different values and different measures of quality of life. So when did symptom management become an actual science? It has a long history and a long history of lots of different remedies and herbal supplements and lots of tricks and trades that people have tried for centuries, because symptom management is important to us as humans. Today, symptom management is very multidisciplinary. There is not one specialty that owns it. It includes experts from medicine, oncology, palliative, nursing science, and translational medicine, and it's a rapidly growing field. And it focuses on both prevention and treatment of symptoms as it relates to cancer and cancer therapy. So how do we address symptom burden and quality of life? A little bit of history. I think it's fascinating that for over 1,000 years as humans, we've been trying to find ways to better manage our ailments. This famous encyclopedia was written by this Greek physician, which detailed all the different herbs and the medicinal power of herbs that could potentially help people suffering from different conditions. And the Greeks believed in the theories of humors, which is that our different body fluids actually impact human health, and that these herbs could better address when humors were out of balance. And so these monasteries developed and would cultivate these herb gardens to help resolve these imbalances. And there was a local apothecary who would provide these herbs for various remedies. And this continued. And in many ways, as you'll hear, it has continued in many ways through our supplement industry and some of the ways that many of you are approached by different industries with these various remedies. And in the US, we have a large amount of supplements that we use. It's a huge revenue producing industry. And we it's not a regulated industry. So as cancer survivors, you can sometimes be vulnerable to different advertisements and unregulated advertisements that essentially tell you that, you know, a pill can fix things. And unfortunately, it's never that simple. What we do know is that Many of these supplements out there may not have the strongest evidence associated to them, and sometimes when we rely on these less regulated symptom management strategies, um, at the cost of using more conventional therapies, it can actually negatively impact survivorship. So patients who solely focused on these alternative therapies tended to be more likely to refuse more conventional therapies. And in this article, as you can see, this was associated with lower survival. So let's talk now about the actual science and what we do and don't know. So over the years, there have been a number of symptom control trials, and you can see in this graphic as I go through it, some of these may touch on the symptoms that you're experiencing today or have experienced. This includes anorexia or cachexia, the low appetite that can be sometimes associated. Mouth sores or mucosal toxicity has been a great focus of many trials. Hot flashes, neuropathy or numbness and tingling, fatigue. A number of trials have been studies, nausea management, which we have made a great deal of progress on over the years, and many others focusing on skin toxicity, sexual health, anemia, bone health, and arthralgias, and many more. And through these trials, we have learned a few things. One is that we don't have all the answers, and you have all experienced this, is that when you come to your oncology appointment or palliative appointments or primary care appointments, sometimes we don't always have the best evidence-based solutions. These are part of our gaps, and these are things that we're trying to address. And that how we think about what causes our symptoms actually changes over time as science grows and changes. And a lot of times we get ideas from you in clinic when you tell us that something isn't working or that there's a new symptom that you're experiencing. So these clinical practice observations, the dialogues that we have with all of you have been central to a lot of the trials that have developed over time. Sometimes there are unexpected results from clinical trials. As new drugs enter the market, we find that there are unexpected toxicities that then we further investigate. There are preclinical, cell line, and animal data that have been helpful. And so you can see it's a very dynamic range of things that can contribute to what we study in symptom science. And that one trial does not often answer all the questions. So the take home from this slide is that if you're having symptoms that are not being addressed by the current treatments that we're providing, please speak up, let us know, because you never know, it might lead to a future trial that can help future patients. So what are our gaps? So this is a huge topic, and I have decided to, in this talk, focus on three broad areas. One is on dosing. How do we pick the right treatment, the right time, and the right dose for each patient so that things are personalized? I will focus on some known toxicity management strategies. And then number three, it comes back again to you. I think we do need to do a better job, and this conference sounds like it's doing exactly that. We need to engage with all of you more, hear your voices, and continue to address gaps in communication, disparities, and access issues that we know are a problem in survivorship. So I will start with the work that I've been involved with, which also involves, it's actually led by patients. So a group of patient advocates came together, and they really wanted to look at drug dosing in advanced cancer. And they convened, they partnered with a few physicians, but really this was led by them with Ann Loser, who is the key founder and patient advocate, really leading the way. And the idea was there was really no distinction in how we dose certain drugs for advanced stages of cancer versus early stages. And sometimes what we've been doing, or a lot of time what we've been doing, is we've been focusing on that maximum tolerated dose, which can have a lot of toxicities. And so the paradigm that this group of advocates wanted to investigate is this really the best approach, and does it really is it the best way in the advanced care setting for improving quality of life? So they did an over 1,000 patient survey, and I think what it highlights is, again, what you all know is that many patients, the majority of patients, have some side effect from treatment. Sometimes these side effects end up in ER visits or missed treatments. And the range of side effects, I think many of you can identify with. Fatigue led the way. This is a very, very common side effect, and I'll talk about it a little bit more later in the talk. But there were a range of symptoms, including nausea, diarrhea, neuropathy, pain issues, cognitive issues, changes in appetite. And in the advanced care setting, when the dose of the drug was lowered, in addition to prescribing certain medications and providing suggestions, many patients had relief and improvement in their side effect profile. So I think this was the first patient advocate survey that specifically looked at symptom science and how we can better communicate with our patients about dosing and side effect management. And this was a plenary presentation by the patient advocate in ASCO. And I think it has really started a range of dialogues with the FDA and other regulatory agencies about drug dosing. So in summarizing GAP 1, I think it's important as an element of symptom science is that the whole maximum tolerated dose paradigm is currently being questioned, particularly in the advanced cancer setting. And patient voices have really highlighted the importance of good communication about side effects and dosing options to optimize quality of life. And what we've also learned is that as new drugs enter the market, these targeted therapies, these new exciting therapies, are not necessarily without toxicities, and understanding the right dosing for each patient, and really helping all of you, along with your different clinicians, really make sense of the options and limitations of symptom management should be something that we all practice as we treat all of you. Moving on to toxicity management, this schema is actually from a patient from social media. And I think it really highlights that symptoms can happen from head to toe, and that the experience of side effects can be very personal, and no one person is the same. And as I mentioned, we have a lot more new drugs. We are using a lot more immunotherapy. We're using a lot more oral targeted therapies and newer chemotherapies. And they all have side effects. They definitely are treating cancer in better ways. However, that the perception that these new drugs do not have toxicity is clearly false. So I will focus again on another patient survey, because this is where, again, you don't need a physician telling you what side effects feel like. And I always continue to return back to patient voices, because you are the experts in your symptoms. So this was a large survey that asked the question to breast cancer survivors about how they experienced endocrine therapy or anti-estrogen therapy, which is a very commonly prescribed set of drugs. And again, what we find is that almost everybody had some type of side effects, over 91%. The most common symptoms tended to be joint or musculoskeletal symptoms, but lots of others, including sexual side effects, vasomotor, hot flashes. Some even commented on the high cost of medication, which we are also labeling as financial toxicity. And in this group, aromatase inhibitors were the most commonly prescribed drugs. For those of you who are breast cancer survivors, you're a little bit more familiar. For those of you who are not with a history of breast cancer, I think it's the important takeaway is that regardless of any cancer that you have, just substitute a common set of drugs that you're using. And the most important finding of this survey for me was that only 41% of respondents actually got any relief from side effect management strategies that were prescribed to them. So this again highlights that we need to do better, that we still have a lot of gaps in symptom management. But the most important thing that I found was that a third of patients were made to feel that they should be better able to handle their side effects, or that the side effect profile was really not related to their treatment. So we don't have to wait for advances in our symptom science to address that second bullet. I think speaking to the clinicians in the room, we all have an opportunity to really step back as we hear about unusual side effects or things that maybe were not initially reported in clinical trials. This is our opportunity to hear our patients. And obviously, I can't talk about every toxicity that you might be experiencing in this talk, so I chose to focus on 3. One is fatigue, one is hot flashes, and the third is neuropathy. And I hope that at the end, or even in additional communications that happen in the breakouts or even after this conference, we also kind of leave time to discuss any other symptoms that you want to talk about. So starting with fatigue. Cancer-related fatigue, or fatigue, is a distressing, persistent, this is the medical definition, subjective sense of physical, emotional, and cognitive exhaustion related to cancer or cancer treatment. And hearing from my patients, it feels like no other type of fatigue that they have experienced before. It really feels different. It's rarely improved by rest or sleep, which is very paradoxical. And it can be very anxiety producing, because you think you can go take a nap and it would feel better, but it doesn't always do that. And it's one of the most commonly reported symptoms among patients receiving chemotherapy or other targeted therapies. And it can impact quality of life, and it can also impact disease outcomes, because if it's severe enough, it can lead to modification of dose intensity of the cancer therapy. So my message to you is that it's not in your head. This cancer-related fatigue is obviously real, and we have actually identified actual biological factors. When we do research on cancer-related fatigues, we actually see real biological changes that suggest that inflammatory pathways are actually involved, and you can see in the schema that there is an intersection of our immune system and release of different pro-inflammatory levels or cytokines that are shown to be elevated in patients undergoing cancer-related treatment who are experiencing fatigue. And these can even persist for some time after the treatment has actually ended. And there are multiple risk factors and factors that can impact who might have a more severe fatigue presentation versus another person. And it tends to not happen alone. It tends to happen in what we call clusters of symptoms. So it's been associated with other symptoms such as mood changes, and it can be impacted by the stage of cancer. It can be impacted by age, how much drug you're receiving, what other health conditions you have that may compound the fatigue. So in terms of how we work up fatigue, it's important to rule out other things that could be contributing to it. Things like low blood counts or anemia, sleep issues, depression or thyroid issues, and really trying to address mood and sleep disturbances, because all of these actions can potentially help the fatigue itself. And lots of groups are working on how can we better predict who might be more at risk for fatigue. So there are interesting genetic predictor studies that are underway or have been completed that try to predict exactly who might be at risk. And if we can identify which of you are more at risk for fatigue, can we then design our interventions a little earlier to potentially prevent or reduce the risk of fatigue? And so what are we doing as clinicians? I think all of us are trying to routinely screen for fatigue. I think this is important at any stage of treatment or after treatment has been completed. Rule out other contributors, and this is not something that oncology can manage on our own. We need our team players, and this includes our oncology rehab colleagues, where we know that they're key partners in managing cancer-related fatigue. I always get asked, is there a pill? You know, is there one supplement or a pill that can help? And we have some limited amount of data with some of these strategies, and certainly there are trials looking at new agents, some limited data with intermittent steroid dosing, particularly in the advanced cancer setting. And the data with the psychostimulants, things like Ritalin and Adderall, have been a little bit all over the place, and they can have additional toxicities on their own. So overall, there's actually not a good magic pill to take, unfortunately, at this point in time. So what is the best evidence? Our best evidence is actually when the weather is nicer. I hear it's not so nice right now in Minnesota, but when the weather is nicer, actually going outside, taking a walk, and engaging in regular physical activity, the yoga stretch that you all experienced this morning, all those things actually have a stronger level of evidence than any pills that have been studied. And they're actually a prescription in themselves. So actually increasing physical activity is our best arsenal against cancer-related fatigue. But it's been challenging to implement, and I don't want to make it seem like we're there, because it can be challenging sometimes for a variety of reasons to implement and increase physical activities in our cancer survivors. And there are studies that they're actually looking at those barriers and how we can do better in terms of supporting all of you in these interventions. And then NCI is also very much interested, well, what if we take some of these exercise or non-pharmacological interventions and combine it with some of those pill therapies that maybe haven't shown as much of an effect? What if we combine these strategies? Can we do better? So you're going to start seeing some clinical trials with those combination strategies. And as I mentioned before, we really want to find additional markers or biomarkers of finding who's at risk so that we can support you earlier before cancer-related fatigue gets more problematic. So these are some of the gaps that we're trying to answer through survivorship and symptom science research. Moving on to hot flashes. I know regardless of your type of cancer, whether you're a prostate cancer survivor, a breast cancer survivor, or any other type of cancer survivors, many of you have had some experience with hot flashes. And this can be due to chemotherapy effect or due to the use of certain injections and oral drugs that can all increase hot flashes. It can happen in men or women, and it tends to be worse in younger patients sometimes, or those coming off of hormone replacement therapy. But it's a variable presentation, and you can see it at any age. And it can have many downstream effects. It can affect your mood, sleep, and cause anxiety. So it's not just the hot flash, but all the other effects it has. And it can tend to also cluster with symptoms of fatigue, insomnia, and mood disturbance. This busy diagram tries to tell you that we're still trying to understand exactly what is the cause of hot flashes. There's a little bit of hand waving in terms of what causes hot flashes, but we think there is a thermoregulatory set point in the brain, and there is an imbalance that happens as a result of menopausal or hormonal changes due to our cancer treatments, and it leads to this altered set point response, which then leads to hot flashes or vasodilation. And so what our treatments try to do is to restabilize the set point, and by doing so, we can essentially lessen hot flashes. So how are we doing with this? I've had a lot of success in this area. Now you can tell me differently, because it hasn't worked for every patient. But in general, what we have seen is that we have a range of drugs that have been shown to reduce, they don't eliminate 100%, hot flashes. And so the most commonly used ones I've listed here, and they tend to be in that antidepressant family, such as venlafaxine. And it's always important to look for drug interactions, particularly if you're on certain cancer treatments. But then some of our neuropathy agents or neuroleptic agents, such as gabapentin and pregabalin, have actually been shown to be very effective. You find a lot of repurposing of drugs in hot flash management, where we take from other conditions, and they seem to have worked in hot flash management. A newer kid on the block is oxybutynin, which is previously indicated for overactive bladder, but it's actually been shown to be a very effective hot flash agent, and was previously published in breast cancer survivors. And now there is a prospective study in men with prostate cancer and their hot flashes using oxybutynin. And then for times where it's completely refractory, not responding to anything, we do have limited data about a one-time shot of medroxyprogesterone in breast cancer, where it can sort of reset that thermoregulatory point and reduce hot flashes, although different oncologists and patients feel differently about this, since it does have that hormonal component. And there have been also lots of trials that have been negative. And so you may find on this list things that you have tried that you think are helpful. So not questioning that. But when we have actually looked at things like vitamin E or soy supplements or flaxseed supplements or magnesium supplements in controlled randomized trials, they have not been any better than placebo. What also has been shown to be really beneficial is non-drug therapies. We know that even a modest reduction in weight can help reduce hot flashes. We know cognitive behavioral therapy can be potentially helpful, and also some positive results from yoga and relaxation, as well as smaller results from acupuncture studies. I do want to acknowledge that we know that access to acupuncture services is now a huge gap in itself, due to limited insurance coverage, and certainly COVID also restricted access. So we're continuing to find new drugs that can better manage hot flashes. You may have been approached by cooling devices, cooling watches for hot flashes. It's important to say that we don't have good, strong data for these. However, studies are going on to see if we can find newer strategies for hot flashes. Moving on to my third toxicity that I was going to cover, that's neuropathy or numbness or tingling. And it's part of that spectrum of all the different neurological complications that we see in cancer and from cancer treatments. And we can see changes from cancer itself, the nerve endings or peripheral toxicities, or even central toxicities for patients undergoing certain treatments, or with those with involvement of cancer in the brain. And the abbreviation that you might see sometimes is CIPN for chemotherapy-induced peripheral neuropathy, and it can be associated with pain, falls, because it can affect your balance. It can affect your ability to perform certain activities of daily living. It can be sometimes hard to put on earrings or do buttons or close zippers. And all of these things can impact quality of life. And it can also impact the amount of drug that we're able to give patients. So if the neuropathy is progressing to the point where it's actually impacting your function, we do have to reduce the dose of the drug. And sometimes in certain situations, not all situations, this can be sometimes associated with worse outcomes. And there's been over 50 or more studies looking at, can we prevent neuropathy? Can we prevent CIPN? It's the dream if we can actually prevent the toxicity from happening. that is a much better approach than waiting for the toxicity to happen and having to deal with all the ramifications. The problem is that none of the studies that have been actually controlled on a large scale have been shown to be beneficial in preventing neuropathy. And so recently, all the best minds in neuropathy research got together and again appraised all the evidence for neuropathy. And really, in terms of prevention, the takeaways were that we need to always counsel you all about the potential risk of neuropathy. And if you have pre-existing neuropathy from other conditions, we really need to kind of have a dialogue about the pros and cons of our cancer treatment. So really evaluate risk and benefit in an open dialogue. And the second big recommendation from this best minds in neuropathy research was that we need to actually discourage harmful supplements. I started out the talk by talking about the supplement industry, and in general, they may not have a beneficial effect. We don't have evidence to support a lot of their uses. However, there was even one supplement that actually was shown to actually worsen neuropathy. So I think the potential for harm is great in this setting. And then there are lots of studies that are looking at acupuncture or using cooling and compression, exercise, and other things. But right now, we don't have recommendations to use them outside of a clinical trial, but these trials are definitely ongoing. And similarly, the European Society of Medical Oncology reached the same conclusion that probably our most promising prevention strategies are listed here with acupuncture, exercise, cooling, and compression. However, at this moment in time, really they need to continue to be tested in the clinical trial setting. But data are coming, and we're continuing to work actively in this space to advance symptom science. And similarly, with treatment, lots of trials have been also negative. The only positive, well-controlled trial that we have for treatment of neuropathy is with the drug duloxetine. However, we have the opportunities for dose delays, reduction, or termination of therapy for patients who are very symptomatic. And then lots of studies are looking at kind of different topicals, acupuncture again, exercise, scrambler therapy. And again, the level of evidence is not as strong for me to always recommend these as a standard therapy to my patients, but absolutely encourage it as part of clinical trials. Similar idea from the European Society when they looked at all the treatments. We use a lot of these agents, but for example, one of the most commonly used drugs that we use for neuropathy, gabapentin, was shown great promise in diabetic neuropathy. However, the phase 3 study in a cancer population was actually not positive. So again, we need lots better treatments, and this is something we're working on. So how do we approach this in the clinical setting? We need to continue to communicate with you, really hear about your symptoms. It's not, you're not having neuropathy, are you? It's really taking the time to either through standardized questionnaires or really assessing your symptom burden, I think is really important. Really looking at your goals and lifestyle. I've had musicians who come to see me, and the risk of neuropathy is much greater for them than maybe somebody who's not playing the violin. So it's really understanding what is important to you in terms of quality of life. And the idea of making decisions together or shared decision making, and really sharing with you what type of limitations we have with our existing management strategies. And continue to invest in well-designed future trials. So thank you for all of you. The way that we're moving the science forward is with cancer survivors, such as yourself, participating in clinical trials to invest better in these strategies. So summary of GAP 2 is that we need to do better. I think we have made some advances, but certainly we have a long way to go in terms of improving symptom burden. And I'll close with the most important segment, which is that we need to improve patient engagement, equity, and access. And so I referred to this a little bit earlier, which is clinicians have not been are notoriously not very good at soliciting what symptoms you're having. So when we have a clinician ask you what symptoms you're having, versus having you fill out a questionnaire or fill an electronic survey, what we find is that you tend to report more when you're doing this on your own. And it's this is the field of patient-reported outcome, or PRO field, which is that when we actually ask all of you what you're feeling and what your symptoms are, and then are able to monitor that and act on it, not only is it more accurate, but it actually shows better survival in certain cancers. This is a study in lung cancer where patient web-based monitoring of symptoms, just knowing the symptoms and then feeding it to the clinician so they can make certain decisions, actually led to better survival. So again, highlighting how important patient voices are in symptom science. And taking this further, I think as you're seeing in this conference, and even how we open the session with patient voice, we need all of you actively engaged in how we design our clinical trials. And so the idea of scientific advocacy and having patients actively engaged with us in our symptom management studies is a key priority that all of us are very much passionate about. We also know that not all patients are treated the same, and they should be. And that treatment should be personalized. And one of the priorities of one of the cooperative groups that Anne and I participate in, the Alliance Clinical Trials Network, one of our priorities is to really look at provision of symptom management and supportive care strategies, and look at the disparities where we actually see that that there are known disparities in how patients are referred to supportive care services, have access to different symptom management strategies, and we want to better catalog these, but also design interventions to better address these. So in summary of symptom science, I've kind of taken you through a whirlwind, is that symptoms can be impacted by many things, including who you are, what your life is like, what your cancer is, and what your cancer treatments are. And we are continuing to work on personalizing symptom management with better biomarkers and more targeted therapeutics. We're making progress, but we have a ways to go. We need to really understand that the inequity issues that we do see happening both in cancer therapeutics as well as cancer symptom management. And it's not a one-person show or a one-physician show. This is really multidisciplinary. We need lots of disciplines really working together to provide that holistic symptom management to our cancer survivors. And just in the last 5 to 10 years, I've seen tremendous progress, and I do feel very hopeful that in the next decade there will be more, and we would see better patient outcomes, better patient experience, and ultimately better quality of life. And as we envision what this future looks like in terms of cancer survivorship and symptom science, you will see themes developing in terms of lots of science focused on understanding what is the basis of these different toxicities. And I'm sure all of you have heard about precision medicine as it relates to drug therapy. But I think the idea of precision survivorship care, how can we better personalize the survivorship experience so that with each survivor being a unique individual, how can we better meet your needs? And lots of understanding of newer drugs and how to better design interventions, and then implementation. It's not enough for us to know that strategy A works. if we can't actually bring it to the community and actually coordinate care and actually improve access, it's essentially meaningless. It can't just exist in clinical trials or guidelines. So with that, I will stop to make sure that I have an opportunity to answer questions, and thank you so much.
Dr. Lusberg, that was really wonderful. It was a wonderful description of just, I think, the importance of not only as for patients, I hear about it, one, to just see how the field has advanced over the course of the last number of years and decades. I also think to myself, as a clinician, like how important it is that I know how my patients are feeling and how they're doing. And I'm wondering if you have suggestions for our audience for family members and for patients, like how can they best communicate that when they're coming into visits, knowing that they have so much to discuss during that limited amount of time?
Yeah, such a great question, Anne. And I think we're still trying to understand how to best do that. I think the old tried and true way of coming in with notes ahead of time certainly works. Just kind of gathering your questions. I know with COVID and visit restrictions, that severely, in fact, and I think we saw an effect. Caregivers, thank you for all that you do in the audience, because I think you are such an integral part of the care. And I saw how it really impacted communication when my patients did not have a trusted someone with them in the room. So as visitor restrictions lift, which in many places I believe they are, I think having a partner with you in the room can certainly be helpful. Having notes, different healthcare facilities feel differently, but I personally do like the patient portal for certain questions. So feel free to use your patient portals if you see something or hear something that is confusing to you. I think that's another strategy. We do know that lots of agencies, including the FDA, are looking at better integration of web-based patient-reported outcome monitoring. It's very sketchy right now throughout the country in terms of which centers are using it outside of research. I think that's going to be ultimately the future, where if we actually have a streamlined way of getting electronic patient surveys and also making it easy for the clinicians to act on the critical findings, I do see that as the future in the next few years.
Yeah, I know. I agree with you. I think that's going to be just a really important part of things. The whole fact we're piloting right now a patient app where patients can, give us their symptoms on a regular basis, and we're trying to figure out exactly how to utilize it. Probably much like your program.
Yes.
Yeah. Yes. I'm curious to your thoughts on just, as we think about precision medicine and who benefits from what medications or who's going to get these toxicities, if you have thoughts about, just how the field is changing from that perspective of us understanding who might be genetically at risk for some of these toxicities or who might benefit from the therapeutics we're talking about.
Yes, it's really the state of the art question in symptom science, because lots of work in terms of where the field was, let's say 5 years ago or 10 years ago, was we would identify one gene that would be shown to be associated, let's say, with neuropathy or cognitive dysfunction. And then another group would come along and do a separate study, and then they would find another gene. And so the problem that we've had is that we in terms of confirmation of these genetic findings, that's been the biggest gap. And part of the reason is that it's probably never just one gene, but a series of genes working cooperatively together. So you're going to see a lot of work in terms of what we call multiplex approaches, where we take genetic factors, but also look at protein factors and clinical factors. So what I would love to see is what I call these precision risk calculators that take into account the genetic factors, but also the clinical factors. And then I hope, my hope is that we'll be much more advanced in 5 to 10 years. But right now, what we have is thousands of papers showing different genetic markers, and it's been very hard to validate. But how will we use this information? Let's say we do have that risk calculator. I think then we can better counsel our patients about potential for different toxicities. And then perhaps, just like therapeutic, have these basket trials where they kind of target patients towards certain defined therapies. We could then select for patients most at risk for a different for a given toxicity, and then focus them in those clinical trials. I think this is where we want to go in symptom science. We're not quite there yet.
Thanks for sharing all that. Well, I just want to thank you for your time today and for joining us on a Saturday morning. I know we've all learned something from your talk. And I think as I listen to you, just thinking about our patients and families, I think that how important it is, as you showed, that they're sharing their symptoms and how they're doing, but also really talking as the field's evolving about the pros and cons of interventions and just how necessary that is. So thank you again. We appreciate having you.
Thank you. Thank you.